Energized? Maybe? Question mark? I don't know. Okay. Well, welcome to the first panel of the day, which is really about being fired up about fire. My name is Nat. I'm a technical officer in the Digital Health and Innovation Department, and it's great to be here with all of you. I coordinate the Smart Guidance Program of work, as most of you may know. So the concept of open standards, open content, and FIRE is really one of the fundamental pillars of the work that we do at WHO to provide normative guidance to the world. And so I'm here with your fellow panelists to really talk about why they're all fired up about FIRE. So maybe I'll ask each panelist to first introduce themselves, your name, which organization you're working with, and then tell us all why you're all fired up about FIRE, why you're interested in the standard, and what problems do you see FIRE solving. So.
Good morning. My name is Jean-Philbert Nsengimana. I work as the Chief Digital Advisor at the Africa Centers for Disease Control and Prevention. Previously, I served in the government of Rwanda as Minister for Information Technology and Youth. I'm fired up. This morning, I can hear in my voice. And for me, the reason to be fired up is I see FIRE as being part of the solution that will help us, Africa, achieve our universal access coverage goals. And this is because of three main reasons. I see a direct link between FIRE and affordability of care. We all know, and we are here because we believe that there is no such thing as good health without good data. And we cannot have good data if we are not following standards that allow patients to be able to get continuity of care regardless of where they are and be able to be the custodians of their own health. Before FIRE, it was extremely difficult to achieve that objective. So with good data, we are able to drive affordability of care, especially for those people who only depend or almost only depend on the telecom infrastructure, the mobile infrastructure to get access to preventive, but also to curative care. So that's number one. Number two, I'm fired up because I believe that the health sector has a huge potential, especially at this moment in time, to also become an economic sector for the continent. If we continue treating the health sector as a cost center, if the Minister of Health is not a friend with the Minister of Finance so that health can attract investment, we're not going to move far. But we understand that health is an investment. And the health tech innovations that are expanding UHC should allow the innovators to grow, scale up their solutions, and create jobs. And that cannot happen if we don't follow an open, standard open stack approach. So FIRE is really important. This country, Kenya, is the birthplace of M-Pesa. It has demonstrated that fintech can become an engine for socioeconomic transformation, and health tech could be the next sector that follows in the footsteps of fintech. And personally, the dream that I have is to see the first health tech unicorn coming on the continent. There are 10 unicorns in Africa. All of them are in the fintech, not a single one in the health tech. Because this fragmentation, the pilotitis that has plagued the health sector, has resulted in stunting of health innovation, health tech innovations. So if we can use FIRE to break those silos, then we can start seeing health tech innovations growing across the continent. And that's why, from an Africa CDC perspective, we are really fired up. And my colleague, my friend Steve, we are determined to put Africa on fire. Thank you.
Thank you, Phil.
Hi, everybody. Good morning. My name is Amaranth Sickle, and I am a Senior Digital Health Advisor with the Bureau for Global Health's Center for Innovation and Impact at USAID. And There were so many good points that you made. I will take a different approach because you stole so many of the points that I wanted to share. I'm fired up about FHIR because of its ability to facilitate continuity of care so that you have the right information available at the right time for people to make informed decisions for their healthcare up and down the healthcare system, no matter what level of the healthcare system you're operating at. FHIR is what enables that level of data exchange so that you can have that dream of continuity of care. And on a personal note, I actually entered this space because of the vision of continuity of care. And I entered it focused on patient IDs because I saw that as the hindrance. If you don't have a unique patient ID, then how can your records move with you? And I very quickly realized that that was just the tip of the iceberg, and that actually there were so many other facilitating elements that were not in place, so that even if we did have unique patient identifiers, that dream of continuity of care was still going to be so far out of reach. And so that really is why I am fired up about FHIR, because that's one of the critical enablers that will allow patients and care providers and health system managers to have access to the information that they need at critical junctures to make the best decisions for health. Thank you.
Hey everybody, my name is Graham Grieve. I created FHIR. Thanks. And I did that because although I was involved in the standards process internationally, I didn't think that the standards we had were solving the problems that we have, and that anywhere in the world, the problems we have. They didn't serve the care my family needed, or your family needs, wherever you're from, and I didn't think we were on a path to doing that. And so I created FHIR to change that. And remarkably and very surprisingly, it worked. And here we are. And across the board, I'm here, and I have been for 15 years nearly now, 15 years, to serve the community, to help however you want to make healthcare better for the people in your lives, people in your countries. And it's the reason I'm fired up about FHIR is because it's working and because of the community that it's created, all devoted to making healthcare better. And here you are, part of that community, and it's a real pleasure to be here. Thank you.
Good morning, everyone. My name is Matt Berg. I'm the CEO of an organization called ONA. We develop digital health apps that have been big adopters of FHIR. I'm fired up about FHIR for a couple different reasons. One is to kind of steal from Dr. Hani, is despite working in digital health for over a decade, realizing that we have really still haven't transformed patient outcomes. And to achieve that, we have to achieve interoperability or solve the fragmentation in health. And when I say interoperability, I mean that whatever provider or the patient, wherever they seek care, we have a 360 view of that patient's information, so you can ensure we provide them the best care possible. Otherwise, you can call that continuity of care. I'm fired up for FHIR too because of the timing. Africa has an opportunity in particular. This is kind of like the cell phone landline issue. If you deal with the US in healthcare, it's a bureaucracy because all these legacy systems. FHIR provides a foundation to build your health systems right from the very beginning. I'm fired up about FHIR because Africa has the opportunity, and a lot of the rest of the world, to build systems. I think countries should invest in their data model and not specific platforms. And I'm worried that without FHIR, we have this idea of monolithic interoperability, where we pick one platform to solve the interoperability issue, and that's not the way to solve the problem. There's many other reasons. I think FHIR is beautiful from a technology standpoint. You can explain health in a common language. I'll talk about that more later. But I think for me, those are kind of the key reasons why we're really excited to be on this journey. And also just want to say, this is awesome, so thank you, Stephen and team. I wasn't here yesterday. It's wonderful to see 300 people now. It was a small, very small group when we started this journey. Now it's quite a bit bigger, so awesome.
Thanks. Good morning, everyone. My name is Stephen Onye, the president of Helena, but I also run a company called IntelliSoft Consulting Limited. We're based out of Nairobi. We're a software development company. And I think just picking up on the queue, I'm fired up because I think in addition to everything that's been mentioned by my panelists here, I think for me, it's the fact that when I encounter fire, there's something probably unbelievably simple about it. And when I learned software development many years ago, it was extremely painful. And it was very difficult to get anything done. The technologies were really not very friendly. Getting anything to work would take a really long time. And so I think when I got into running a business, and Matt and I speak about this all the time, you have to think about how much it takes to build a software application or solution. And time matters, and the quality of the product matters as well. And so encountering fire and everything that it presents, including demystifying how to actually build good software, it's human readable, so you don't need to depend on an engineer who probably try and convolute everything for you, and because you don't get it. You can actually read for yourself and see what's going on there. You can contribute even if you're not an active developer. I think a lot of that and everything's been said, but I think I would say more importantly was I met Graham last year in Zanzibar, and I still remember having a very deep, heart-to-heart conversation with Graham, and everything he said about where this all came from. I think for me that was extremely profound. Just speaking with somebody who developed this thing that we all love so much, but also I think a lot more hearing what motivated him. I think gave me a lot more reason to continue investing in fire. Thank you.
Thank you so much, everyone. And I think we all can agree that there's so many reasons to be fired up about fires, regardless of what you do in this field. But first, I'd actually want to go over to you, Graham, as a father of fire. If you could share more about what the global state of fire adoption is, what HL7 and the fire community is doing to support the rest of the community to really adopt fire.
It's really hard now for me to describe worldwide implementation because there's just so much of it. But I counted recently, and I know of fire projects and fire implementations in 90 countries. I mean, personally know of them. And projects, and there's hospital projects, and there's open source projects, and there's student academic projects. And some of them are technical, but others have made real difference to patients and to outcomes. And some of them are cross international bound borders. So later we're going to talk today, Diego, my friend, is going to talk about international patient summary. And that's going to change, I think, a lot of our experience of moving between countries, which we all do for one reason or another. But in terms of supporting the community, from the beginning, we made fire free under Creative Commons public domain. Those of you who have been around standards long enough will remember just how big a deal that was. And now we just take it for granted. Of course it should be, but it certainly wasn't taken for granted when we did that. And the combination of fostering virtual participation, open source tooling, free content, free standards, free education material, and then actively pursuing collaborations with Helena, with WHO, with others. That's our strategy to support the community, both in Europe and America, but also the rest of the world. And personally, I really care about that when I started doing this, we were too focused on only one part of the world, and one of the things I'm most pleased about is that we changed that.
Thanks so much, Graham. And I think everyone agrees with you that this is super exciting, and they're very grateful that it is open. And I think that's super allows for everyone to get involved in actually creating the standard as well. And so I think we can all agree that FHIR is kind of the way forward, but the next question that always comes up is then, where's the money? So Amaranth, I'd like to hand over to you, and if you could share with us why donors like USAID are investing into the standard space. What are you hoping to achieve in the shift in investments and what those investments would achieve? And then also how funders themselves are changing to better support this effort, because then I think we've all heard many times that sometimes the lack of interoperability is often due to funding that comes from many different donors, and sometimes the same donor, but for many different things, to put it lightly.
That was very well put, Nat. Thank you. And it is a big problem. And actually, I'll start there with the problem, which I think was really well outlined yesterday. The problem of pilot systems that are demonstrating proof of concept, the problem of fragmented systems that are not able to exchange data with one another, the problem of duplicative systems that are very, maybe not perfectly identical, but self-similar and do a lot of the same things, but require completely separate support structures. And that created a pretty unsustainable environment for digital health and for digital transformation to really impact the health sector. And we've learned some really painful lessons, I would say, as a digital health community and also as a funder community. And I think a lot of those lessons came home to roost in the response to the Ebola outbreaks in 2016-17, where there was one of my colleagues, Adele Wagaman, who many people here know, is writing a report where she researched the flow of information to support the Ebola response, and what she found was a fog of information. So there was information, but it was not available in the places where it was most needed at the time it was needed to support a robust response to a fast-moving and deadly disease. And coming out of that very painful experience, USAID came out with its inaugural policy on digital health. And among other things, this inaugural policy, called the Digital Health Vision, underscored the importance of an architectural approach. And it was a 5-year vision, and so it came out in 2020, and it was sunsetting at the end of this year, and we needed to update it. And so as a part of that update process, actually, we engaged in a user-centered design research process where we reached out to our colleagues all over the world who are on the front lines of making this digital health vision a reality through our programs, and we reached out to them to understand, what are your barriers to doing this? What are your barriers to doing things like taking an architectural approach, which includes using standards when you are supporting digital health implementations and interventions? And one of the things that came back to us loud and clear, actually, was that for a lot of our colleagues around the world who are responsible for overseeing and investing in digital health solutions, they didn't know what we were talking about. Like, what is this architectural approach that you're talking about? And so we took that to heart, and in the digital health position paper, which we released in October of this year, which is the successor to the Digital Health Vision, we tried to break it down for our colleagues. We tried to underscore what it means to have an architectural approach. And we put forward 6 what we were terming practices, 6 promising practices that will enable health sector digital transformation to unlock, going back to Matt's point, to actually unlock improved outcomes in healthcare. And the second promising practice that we underscored was requiring standards in order to achieve integrated health service delivery at scale. And so I think from our perspective, it's very clear that standards are what we need in order to unlock that impact. And you said how we're changing. We're trying to change the way that we talk about this work so that it can be understandable to colleagues across all of our operations. And so really underscoring the ways that standards can contribute to health outcomes so that colleagues who aren't spending all day thinking about digital health and thinking about data exchange can understand why this is so crucial to their work and why they need to champion it as well. And I'd say one other shift has been really exciting that I've seen within the last 5 years is I feel like originally when we were talking about data exchange and interoperability in the health sector, at least within USAID and a lot of the communities of practice where I sit, a lot of it was talking about data exchange so that you didn't have duplicative platforms, but it wasn't necessarily talking about data exchange to support integrated healthcare service delivery. And that's a shift that I've seen with the refocus on primary healthcare, this shift so that we're focusing on delivering integrated healthcare, and as a result also, we need interoperable platforms. And that to me is a really nice shift because it means that we're able to have form-following function in a way that's really nice within the health sector. So yeah, I think we're really excited about the potential for standards and in particular FHIR to actually unlock impact within our investments in digital health. And we're investing in our own capacity as well as standards, and I think there's a lot more that we could do to be investing in standards, but one thing that I'm proud to share a little bit about now, and you'll hear more about if you are at the Global Digital Health Forum, is our investment with WHO in smart guidelines to help make sure that standards are being rolled out easily throughout our programs around the wheel, and that we don't recreate, throughout the world, and that we don't recreate the wheel when we are investing in digital health solutions. So for more on that, come to our panel on Wednesday.
Thanks,
Nat.
Amaranth, for that plug. I think we're all excited to really see these investments come to fruition as well. So now I'd like to hand over to Phil and also Stephen. If you could share more about what regional organizations such as Africa CDC and Helena are doing to really advance the use of FHIR and DPI adoption. I think it would be great to hear more of what challenges you actually see in adopting those standards and the DPIs, and also specifically if you could tell us more about the Africa on FHIR initiative.
Thank you, Nat, and a great moderation because you also stole my points. So you reiterated very well. But I want to say that at African Union, we are doing quite a lot to promote this approach of open architecture, open standards, full stack approach. In fact, if you can just Google right now, Africa Health Information Exchange, if you just put that string in Google, it will lead you to a document, and when you go through the document, you realize that Smart on FHIR has been identified as one of the key standards that the African Union is proposing, promoting, and I think we need to get to a point where we actually mandate the standard so that it can be enforceable. Because as you alluded to, one of the challenges of having something that is just available, promoted, but not mandated, especially in our context, is people have the choice of, following it or not following it. So the question is there a carrot or a stick for people to adopt this approach? Now, sitting with the man who created it, maybe you don't want any of the carrot or stick, or maybe just the carrot, not the stick. But I think that given the high expectation in terms of accessibility, affordability, and quality of care that comes with standardization, I think it would be good to think in those terms. And I was having a conversation earlier on with my friend Alain, and was talking about the kind of carrot that the US, for example, has put in place, supporting companies that want to migrate to an open standard and open architecture, and then later on making it difficult for those who have refused to comply to keep holding patient data, for example. So that becomes the stick. So I think when I reflect to what we need to do, I think we need similar measures in Africa. How do we incentivize the innovators that are putting their time, their effort? In our case, there is no money to give them directly to migrate. But understanding that they can do things much simpler, as you said, Steve, much faster, and that their innovation could be easily more adopted by governments to be part of the public health delivery systems. That could be a huge incentive. But I think we need to get to a point where we say, look, refusing to comply or to go open has actually a cost. Somebody has to pay that cost. And that cost is usually passed on to the citizen. And we are in a resource-constrained environment. We don't have resources to waste. And I think we need to get to a point of saying, look, let's legislate common sense. Let's make common sense mandatory. And let's find ways to discourage actively those who are not able to move with common sense. So I think if I can summarize what our thought process, I would summarize it in 3 C's. First C is capacity. We need to build the capacity. There is still a long way to go to ensure that our developer communities know this approach. They know the standards. They know how to use them in their products. The second C is the community. We need to build strong communities. Unlike countries with a high ratio of tech experts per capita, for example, I'm thinking about India, where it is easy to find a community of developers that have been trained in a specific area. We still have a long way to go. So we need to cascade these kind of conversations at community level, so that in each country we mobilize those communities and they rally around those standards. We build basic awareness, literacy, but also we build competency and advanced skills in these technologies. The third one is the cash. We need to find ways to put money behind the right thing. If we don't put our hands where our mouth is, we can talk until cows come back home. No change will happen.
Thanks, Phil. Stephen?
Thanks, Nat. Just building up on what Phil has mentioned, just really quickly, I think I agree with Phil's last point about governance. I think we're getting to a point where the point has been proven that standards matter. And I think we need to move a step further to operationalize these kinds of statements. Thanks to people like Graham for building something really good. But I think by itself, it's not going to get life. It needs a structured governance ecosystem around it. And I think just to give a couple of examples across the continent, Nat, as you've asked, a country like Kenya, for example, has actually included specific mention of fire in the law. So the Digital Health Act and the regulations that are currently going through public participation. If any of you is interested in the regulations for Kenya's Digital Health Act, we can share those. They actually call out fire as a standard. And one of the things that has been proposed by the local ecosystem is that to get onto Kenya's superhighway, digital health superhighway, your system will require to be compliant with the standard, and one of those standards is fire. Others that have been mentioned are guidelines like smart guidelines, but I think that, as Phil is saying, we need to get there because we can't keep trying to argue for a point that has been made and has been proven through evidence. So I think that's one. Then secondly, I would say that from a HELINA perspective, with support from the Global Fund, we are working with different organizations to set up the first Standards and Interoperability Lab in Africa, hosted very happily at the Health Tech Hub in Kigali. And what Phil also mentioned is that one of the great things that Phil is very humble. He did mention that he's got a couple of flagship projects that he's running Africa CDC. And one of those that is very important is the Sandbox flagship. And so we are plugging into a lot of this work that Phil is leading to basically provide a platform where people can actually come and test your systems, show that they're compliant, that they can participate in the ecosystem. And so that's something that we're also doing. Thirdly, as HELINA, as Graham mentioned, we're the Africa affiliate partner to HL7, which means that I'm really happy that Diego is here as well. We're working on a plan, as Phil mentioned earlier, to promote and to provide affordable, competent, and skilled training to various audiences, so non-developers, developers, leaders, to basically make them competent in fire. Like I mentioned earlier, we strongly believe that a lot of the work we're doing here will be carried over and sustained by a competent workforce. And we probably heard the Minister for Kenya saying that Kenyan government is working on establishing a former cadre of staff of public health informaticians. Phil at Africa CDC is running a program on public health informatics fellowship that is just going to start off next year. We need skilled professionals, and they need to be recognized in government. As long as we don't have that, a lot of this great work will always fall short. And so that's another thing we're working on. And I think lastly, just want to mention that all these discussions fit in very well within the framing of full stack that we've been discussing. The S is for standards. And just want to wind up on that note. Thanks, Nat.
Thanks so much, Stephen. And lastly, just a question for Matt before we open up to the audience. If you could share a bit more about how developers are adopting FHIR into their solutions, and specifically, why did ONA, the company you founded, decide to fully invest in the FHIR approach?
Thank you. We've been involved in the development of kind of the FHIR native work with Open Health Stack, kind of from the beginning of Google and WHO. When the idea first came out around, hey, can we develop this idea of smart guidelines? Can we develop FHIR native apps? It was exciting because this idea of reuse of content, I think, was compelling. I think the idea of FHIR native, which reduces the friction of interoperability, I think, was also really exciting. It was one of those things that we looked at doing. This all happened around the start of the pandemic. And it was kind of a sobering time, locked in your house, not sure about the future. And we were thinking about our own journey as a company in digital health. We've been working on OpenSRP version 1 for about 8 or 9 years, and thinking about what do I want to do with the rest of my life, And I was realizing that as a company, we were basically contributing to the problem, and that we were developing a platform which we were trying to push onto countries that promoted a proprietary data model and a proprietary way to configure your logic. So in a lot of ways, even if they adopted our tool and had an impact, we weren't promoting our own book, so to speak. So we made the decision to go all in on FHIR at the start of the pandemic and start from scratch to rewrite our platform. It's a journey we've been on with Google, with partners like Intellisoft, SID in the room. And we rewrote our platform from scratch. And there's a lot of surprising benefits from it. One of the reasons also why we did it was we saw the need. Countries where, if you want to use like an electric car analogy, we're interested in FHIR. We're starting to want to put in the charging stations, so invest in FHIR. But there was actually no electric car to drive. There's actually nothing practical for them to use. It was kind of a concept. It wasn't something you could hold in your hand and make easy. So we thought if we can build a FHIR native app that gave you an alternative to the current digital health apps, that would be the first EV, so to speak. The really surprising thing for me, and I wish I could say I was smart about it in the beginning, was that with OpenSRP 1, we like to think we helped inspire the smart guidelines. The reason is we worked at WHO, developed the first reference ANC app, and we were such a pain to work with. It was so painful for WHO. I think they realized we can never work with a vendor like that again, because basically we had to work with WHO to develop a way to digitize ANC, which is really complex. So it was just a painful process, and then there's like translation from developers to coders and all that. So can there be a better way to do it? And so what's really came out of the thing I love about FHIR is, besides providing a way to represent your data model in a shared health record, it also provides all the ingredients you need to represent your clinical logic, right? Your schedules, workflows. So if you want to do immunization schedule, there's a way to do that you don't have to invent, which is super powerful. So at the end of the day now, we can build, they used to be hard-coded. So I forgot to mention our first apps, patients liked, providers liked, because it did all the workflows you needed, but it was not scalable because we had to code it ourselves. Now with FHIR, we can represent all of our apps now. We have one with OpenSRP 2, one Android app, and everything is 100% configurable now with all the using standards-based logic, which is a huge deal. So we can now provide patient-centered point-of-care apps that serve the provider and patient's needs without compromise based on FHIR. So we really are now an EMR on a phone or tablet, and that's a huge breakthrough. So FHIR enabled us to do that without having to come up with our own proprietary approach. And that's what's going to allow us to create an ecosystem and a community around this methodology. So for us, it's been a really smart move. It was a long journey, but at the end of the day, we have something that's better without any compromise. So FHIR without compromise, I think, is kind of where we're landing on it, which is exciting. Thanks.
Thanks so much, Matt, and thank you for sharing that little anecdote for everyone to know as well. So now we have 5 minutes left, so I think we could probably do 2 questions from the audience. So anyone has a question, please raise your hand up high, and then we'll get a mic to you.
Hi, I'm Rubayat from Endless Network. My question is about the link between digital health systems, and health outcomes, because oftentimes in our digital health community, we tend to talk within the community and forget that there's broader links with the health systems crew. I don't know if there's a lot of health systems people here, but it's really important that we talk to health systems people as well to understand what are the gaps that we're trying to solve, right? And I love the fact that we talked about integration of like integrated primary care and how kind of FHIR fits into that. Loved how Graham talked about like the person-centeredness and continuity of care aspects that we're trying to solve with FHIR. But as we know from the WHO flagship report on digital health a few years ago, we haven't really seen a lot of the digital health interventions translate to health impact. So I'm curious, has there been any research on the impact of FHIR on health outcomes, or how health systems have actually changed as a result of this interoperability and the storage of records in a standardized way? Thank you.
Thanks, Rubayat. Anyone from the panel want to take that one?
So what I can tell you is that, and I often regularly say this, FHIR is a technology, and technologies don't solve problems. They get in the way of solving problems, and so that's our goal for the community, was to let people solve the actual problems. And there are projects around the world that have led to real outcomes. But the problem, the challenge is that to do that requires sustained transformation of the healthcare process. You can use FHIR to make fractional, marginal changes to healthcare, maybe same kind of healthcare, but a little bit cheaper. The transformation comes when you use it to create new ways of connecting patients to the healthcare system. Now, in terms of research, the problem is that it requires quite a lot of money to do that, quite a lot of will, and all of the research that I've seen has really been people advertising how clever they were about it at this point, and we haven't yet had enough to do really systematic research into the outcomes. But when we do, I'm pretty sure, and I hope, that people won't really notice the tech, because it's just not about the tech. But on the other hand, it's totally about the tech, about creating a platform that lets us do those things. And then we just take the platform for granted and actually make changes that matter. And so I think it will never be a really clean story for those reasons.
Thanks so much. I think we have time for one quick question. Yes. Can someone get the mic? Very quick, please.
Yeah, this question is for Graham. How about the support for non-human recipients of care, like animal in FHIR? Like, for example, can we define in the patient resource section for herd of animals? Because now the talk is about One Health and then support for interoperability data standards for One Health. Thank you.
From the beginning, we've said that care for non-humans is part of our scope. And we've argued a lot about what that actually means, because it kind of doesn't mean very much. You're all recipients and providers of care. And we have various projects around public health monitoring for agricultural processes, and veterinarian care in, you know, rich or country, rural environments. And really, as far as I can tell, looking at those things structurally, all of us have the same problems around connecting people, connecting processes, describing what's going on properly and connecting those up. And we don't think of those as anything special. In fact, in some ways, they're really good ways to demonstrate and learn from the problems and apply them to humans. And so we really, at the moment, haven't seen anything special. Although I have a project working on with UN agencies around disease surveillance, and maybe we'll learn something from there, but for now, we think it's just healthcare.
Thanks so much, Graham. And unfortunately, I think that's all we have time for today. So if anyone else has additional questions, you know where to find them. But can we get a big round of applause for our panelists? And with that, I'll hand over to Chiney for next steps.